Hold on. Stay away.
Sorry.
She probably has no idea. We just stare at her the whole time. Next slide, please. And the triangle. You've probably seen the triangle before. PBIS did not create this triangle. It is actually a medical model. But basically, how we implement PBIS in a nutshell. We start out with a foundation. And when I go into schools, a lot of times what I hear from teachers, administrators, is I want you to help me with the kids who are in my office every day, my conduct disorders, my antisocial kids. I want to go straight to them. Forget everybody else. I want to deal with these problem kids. And what we explain to them is we have got to have a good, solid foundation of prevention in place before we worry about those kids. When we do our universal piece well, and that means all kids in our building are taught on a regular, systemic basis what is expected in the hallway, what's expected in the cafeteria, and we pull it into the classroom. What does my teacher expect from me to do when the bell rings? I'm in my seat, my materials are out, I'm ready to go to work. When I walk in the hallway for our little bitties, we do traveling position. Our kindergartners often travel with bubbles in their mouths because you can't talk if you hold a bubble in your mouth. So we teach them ways to be in traveling position. And that is done on a regular basis. It's not a one-time deal, it's every day, so that kids know and understand that. We put those systems in place so that we are sure that everyone, and really what it's about is good communication. Our staff all know what's expected in the hallway as well as our children. When you talk about junior high, my junior high administrators and teachers tell me their #1 problem, hands down, is tardy. But if you're in a junior high where every teacher has a different definition of tardy, how is any child ever going to be in class on time? So we put things in place so that everyone in the building has the same definition of tardy. All kids know that. Everyone's on the same page. Makes things a lot easier. When we have this in place, a lot of these kids that we think probably are up here with higher needs respond very well to that, and a lot of those problem behaviors go away. Okay? We say that we want about 80% of our students to be in that range, and that means they have no referrals to the office, maybe 1 or 2. Most of my schools that have been implementing for 2 or more years, it's more like 95%. So if you think about 95% of the students in the school building, regardless of mental health needs, regardless of special ed needs, have 0 to 1 office referrals in the school year, that's pretty good. Gives you a lot more time to deal with the children up here, okay? And when we get into this, where the yellow is, it says around 15% of your kids, that's our secondary tier, where we focus on the kids who are struggling, who continue to have problem behavior. A lot of times those are the kids that may be ADHD, okay? They may have some anxiety related to school or other things. They may have some depression. They're not your serious acting out kids, but they act out quite a bit, and it's more of that minor disrupting the classroom, making a little bit too much noise in the hall, that kind of stuff. We put some things in place because that's where our classroom issues tend to come out, to make sure that we are more regularly teaching specific behaviors in the classroom, the teachers giving the child more feedback about their behaviors to help them increase likelihood for success. Basically what secondary tier is we are reshaping problem behaviors. And if you've got a child who the primary function of their behavior is to get out of tasks that they are very uncomfortable with, they don't know how to do the math, they tend to act up when math time rolls around, we work with our staff to put a plan in place to help the child be able to stay in class for math, not feel the need to act out, and to ask for help without maybe feeling embarrassed by their peers. You know, sometimes kids have a hard time asking for help. So we target specific behaviors and we put a plan in place to help those children succeed. Okay.
Are you ready?
No, just one more second. Right up here, these kiddos, these are the ones that have multiple problem behaviors, and they're pretty serious. Those are the children we actually train our schools to implement wraparound for those kids, to develop that team-based approach, to bring in partners, and we don't ever meet without the family. The family has to be at the table for that, and we create a wraparound team, and that's where we've really focused on getting those systems of care principles into our schools. And about half of my schools have been trained in wraparound. And it's a little more lengthy, more extensive training than what maybe the wraparound academies have been for the same simply because they have to put systems in place to make wraparound work in schools. They've got to have a way to get those teachers out of class and into those meetings if they're needed. So they've got to put a few more things in place in the building to make that work. But they really, they get it, and I have some schools that have actually facilitated wraparound and have had some great success. And they're starting to look at families differently, because that's been kind of the hard sell for them, was how to get them to understand that family perspective a little bit better. And they're getting there. And they're more open to the family having input. It's not bring the family in, sit down, sign this IEP plan that we've come up with, or this wraparound plan. It's engaging mom in the conversation. What would you see as success for your child? You know, what would a good day look like for your child in school? How can we support you to make that happen? So they're really wanting that family voice more, and it's really starting to take hold with them. Okay. PBIS is an RTI model. You know, it's about progress monitoring everything that we do to make sure that it works, to make sure that we're not just doing things that we think might work or that work with this other child. We're looking at specific data about that child, the function of their behavior, triggers that may be there, how can we minimize triggers and help the child respond differently if that stressful situation occurs, okay? We want to make sure that we are focused on just a continuum of interventions. It's not just one thing here, one thing here, one thing here. We do kind of a range, and we try to layer those supports in place for those children. Having the mental health already in the school and working with those providers, regardless of who the provider was, it didn't matter to me. You know, I'm with Mid-South. I didn't care if Families was there, if Life Strategies was there. I want to work with them within this school setting to build in those layers of support that are needed. And helping the school to actually design those supports, and if the counselor is doing specific groups to help a population of children, you know, if the school is not billing for that as a group, then it's not a duplication of services, but we're layering things in there to help the child, okay? And this is just kind of our process for how we teach behavior. We define behaviors for our kids very, very simply, very positively, okay? Example, showing respect in the hallways, walking on the right side, using a low tone of voice, you know, things like that. Making sure that you say, excuse me, if you bump into someone. As kids get older, the hallways get a little chaotic. And so we teach them how to be respectful in those situations, how to be safe in those situations, to walk, that kind of stuff. So we define things very, very simply and very positively. We don't say to kids, don't run, because that opens up a whole gamut of other behaviors that they could do instead of running. We just define specifically what we want them to do. We have our adults to model it, and this is sometimes the hardest sell for adults in a school building, is modeling behavior. Case in point, if I was a teacher, I would never have a no drinks in my room policy, because my Diet Coke or my tea is always going to be on my desk. And it's unfair as adults for us to say, you cannot bring drinks into my classroom if my Diet Coke can is on the desk. Or to say to my students, you cannot chew gum in my class if I have gum in my mouth every day. I mean, you know, we just try to make our adults be more aware of those things. Modeling behavior is going to get it a lot quicker than telling them what to do. We have the kids and our teachers to practice it in the settings so that they understand the behaviors that we want to see. And we continually monitor for good progress, for good outcomes. If we're not seeing it, we reteach it. Okay? And that's really how it works. Oh, the arrows. I'm sorry.
Oh, okay. I'm going, what happened?
The arrows were there.
Let's see, how do I get?
Making slides of all kinds of crazy things. Okay, now to the functions, the things that you all are looking at, okay? I feel like the direct teaching and modeling and the things that we do with children to teach them behavior, we add a parent component if a school wants it, how to help our parents do this at home to make that connection. When we teach our behaviors and we do our behavior lessons, which are called Cool Tools, I don't know why, that's just what we call them, there's always that connection to real life. Why is it important to be respectful of others in the cafeteria? Why is that skill necessary not only at school, but at home when I'm eating? Why should I be respectful? In the community, why is it important? And we always try to make kids understand that it's not just about walking on the third tile in the hallway to be respectful. It's about why traveling to the right of the hallway is kind of a standard in our society, and why is it respectful to do that. So we really want them to connect behaviors outside of the school building. And we focus on doing that with all of the behaviors that we teach them.
Back.
Scaling that up for kids that need it. It's just like with academics. And this is the example that I use because I remember this. If you've got first graders and you're teaching reading to them and you've got 5 that are just not where the other kids are, and you as the teacher know that, you don't kick them out of class. You pull them back to the little horseshoe table, right? And you sit down with them and you spend more time with them, and you may teach them in a different way what those specific skills are. But you look at kids from a place that if you don't get the skill, I'm going to teach you differently to help you get it. We've got to look at behavior the same way, because that's how kids learn. Behavior is learned. They don't come with a computer chip in their little brains that tell them to act out on the playground every day. That behavior has been taught to them and reinforced, so we have to reteach it and reshape that behavior. We use a team-based approach at all 3 tiers of intervention. We make sure that we get people at the table for those teams that know the settings, that understand what is needed. We always want a teacher's perspective. We can't ask teachers to do things and implement things if we don't get their voice. So we have to have them at our planning table for that. We provide professional development and coaching in the schools to make sure that they feel confident to implement various interventions, to make sure that they feel like they are getting the support that they need. We don't do the train and hope model. And what I've learned over the years with this is that schools spend a lot of money with consultants. And you may bring a consultant in, spend thousands of dollars, and they spend the whole day for professional development, and they train your staff, and wow, it sounds great, and then they're gone. And then you're left to try to implement it without any coaching, and that's not how PBIS works. There has to be coaching involved to help schools continue. I push my schools to raise the bar constantly. We can't get complacent with kids, because then things don't happen that need to happen. I push them constantly to keep decreasing their problem behavior, keep increasing the number of interventions they provide to their kids so that they have more options to help kids. And we always have that strengths focus, okay? Working on collaboration. Since the mental health partnership was already there, we had to look at how to make it maybe a little more user-friendly. How do our teachers know how to access that? There were specific things in place. And unfortunately, the trend that we saw, because we went through the school-based mental health network. So most of our schools had a contract in place with that school, and 30% of the services provided were for non-clients, okay? So they could serve any child in the school for a crisis, maybe just to sit down and talk with a child that was struggling. It might be to help a teacher develop something in the classroom to help a child with a specific disorder or problem. And it didn't have to be on a client identified by that agency or Medicaid billable, okay? What we saw happening in some of our buildings was, if you had a child in your classroom that you were struggling with, send them to mental health. And that was our first intervention. That was the first line of defense anytime there was a problem behavior. And not all problem behaviors are mental health related. Often you can connect them if you need to, but then you get into labeling kids with a mental health diagnosis just so you get some help, because you don't know what else to do for that child. And what we saw was that our schools really needed something else to do for that child, rather than just jumping straight into mental health. You know, because then you've got the whole thing, if it's an agency, well, we've got to get the PCP referral. That may take 3 weeks. Okay, then we've got to get mom in for an intake. That may take another 2 weeks. So you lost 5 weeks of intervention time with that child just waiting for something to happen. And the teacher is getting more and more frustrated. So we needed something for our schools to do that was a little quicker than that. Some tools that they could use, some things that they could implement to help the child. Even if that mental health was needed, you can take that 5 weeks and do something. Okay, so we really wanted to kind of connect those dots and increase the way that we collaborate on those kids, so you could start doing some things for the child even though the mental health ball was just trying to get rolling. Okay, what we needed to do was, most of the things that we do with positive behavior supports, and I'm going to share my data with you in just a minute and I'll be finished. most of what we do focuses on data that